I think the investment in behavioral health services is significant for a couple reasons. I think around the nation, it's under-resourced almost everywhere. A lot of the things that have kind of helped the physical health world, the medicine progress, for a long time been left out of behavioral health. It's kind of newer that there's all this equity investment in behavioral health, even like healthcare technology, so behavioral health providers could track outcomes, track their sessions, kind of stay on track with providing more evidence-based care. They were left out of meaningful use. So there's just always been kind of left out of dollars. So I think the acknowledgement from the state was this is an underfunded system, but also realize that the LME-MCOs alone could not solve behavioral health service issues for everyone. We cover a small portion of the population, and I think we do a lot and we contribute overall to what's going on in our communities, but we certainly couldn't do that for everyone. And I think the state's acknowledgement and investment was really important to say it's been an area that's been ignored for too long. There are things that just regional health plans couldn't solve, and I think they stepped in and did the right thing.
Sean, thanks for being here. Really excited to have the conversation. I don't think I've ever told you this, but when I go to other states and I'm talking to health plan leaders there and I tell them, oh, we're working in North Carolina, we're working with Alliance, they all give me the same answer, which is, oh, that's not surprising. Alliance Health is always on the front edge of something. I think that theme of the work that you and your exec team and the whole team at Alliance is doing is actually resonating much beyond North Carolina. So I'm honestly curious, what do you think is the secret sauce that makes Alliance the plan that everyone is looking to when it comes to building new solutions, pushing forward both physical and mental health? What do you think makes you guys so great?
Well, first, thanks for the praise, and that's good to know. So I think there's a couple of things. I think this is actually something that's not just Alliance, but I think we can thank a little bit of North Carolina's design, that idea that there's some populations that we work with that just have needs, this well, that, are beyond what would typically be covered in a health plan. And they set it up so that some local groups that had deep kind of roots to their community and that are not for-profit entities could work and develop more specialized things. So I think the state, has a lot to do with that. So I don't want to just take credit for Alliance. So we have flexibilities. I think if you were reporting to shareholders, would be difficult if you had millions of members across the country where you have to be somewhat more standardized. I think it takes away some of your flexibility. So I think the small regional design where we just have had the opportunity to work in our communities for a long time really gives us an advantage. So for one, we have a good sense of what the community needs. So we're meeting just the people who live there, all the different stakeholders. We have real meaningful conversations and dialogue, and because we live here and because of these partnerships, I think there's a strong sense of responsibility. Like, we have to do something about these problems. It's not okay just to be kind of casual observers and complainers. Hey, it's terrible to hear about the youth mental health crisis, or it's terrible to hear about the opioid crisis. I think we take it very seriously and very deeply that we have to, as a good community partner, do something about it. So I think the conditions are right. And I think one of the things interesting too is you just have a lot of people there who probably have non-traditional backgrounds for coming into a health plan. So you have people who work provider organizations, you have, attorneys who weren't even in our field, you have IT people who bring other kind of innovation not from our field, and then people who've worked with this population for a really long time. And I think just, creative people, and so that's part of it. And I think there's so many good and unique things going on in the treatment space and new ideas. So we're lucky, we don't have to dream them all up. We get introduced, kind of with your company, to people who've had a good idea. We can look at our community needs. We don't have to kind of worry about taking a risk on something and running it through 1,000 people.
Yeah.
We can be nimble enough. And I think our CEO, Rob Robinson, has done a really nice job of creating that environment that, hey, let's look at what's needed. Let's not always just do the status quo. And let's be willing to, we're not for profit. So if we're able to have a residual Medicaid savings or things like that, let's use that to improve the community. So I don't know, it's kind of a long, winding answer, but I think a lot of that is why I think we're able to do some unique things. And I think it's just a culture if we really want to do what's right for our communities.
Yeah, I'm super excited to talk about that culture. I want to maybe start because you said something, which is it's the diversity of the experience of the people who work for us and who we value and that come from the community. And I know that we've talked a little bit, but I actually don't know that I've gotten the full story of your background and what your journey was all the way to become the COO of Alliance. So can you walk me through, like, where did you start? And
Sure.
was the path linear or was it all over the place?
So unplanned, like I'd like to say, I'm definitely not one of those people when I was in school, like one day I want to be the CEO of a small regional health plan in North Carolina as I was growing up in New Jersey and going to school in Pennsylvania and New York. So I'll just start. I kind of was somewhat of I'll just say honestly, a lost college student. All of a sudden, like I'm toward my senior year and realizing I had no idea what I was going to do. I had started off with a pre-law kind of major and then changed to psychology just because I had an interesting psychology professor and I found the pre-law classes boring. And one of my fraternity brothers, he was doing an internship for a radio station or a media company that was making a commercial for this new inpatient psychiatric unit that was opening up close to where I went to school that was going to specialize in treating people who had pretty severe mental illness, but also severely addicted to drugs and alcohol. And that wasn't going to be like in a 12-step model, which was the standard of care back when I was going through school. So I was like, well, I need an internship to graduate, so why not? And took the internship and was really fascinated by the work, and just, in seeing people how, God, what so good care did. So people would come in, in their worst state, you can imagine, malnourished, psychotic, total disconnection from friends and family, and just even a small amount of time of getting care, nutrition, a safe place to live, therapy, medication, just seeing that improvement. Again, there's some hard lessons in that. It was great to see people change that environment, but also we found as soon as people left that environment, things didn't tend to go as well. So it was a little discouraging, but it made me kind of more interested in the broader system outside just doing kind of work within a hospital. So I did that for a little bit, and then there was an opening for a community mental health center in this little Rutherford County, North Carolina, in the middle of nowhere. But I was kind of working not far from Buffalo, and on a kind of a September day when it was probably snowing already, fly down, it was like 90-some degrees, and in North Carolina, I was like, that's a good reason to take a job. Went to work for a community mental health center that doesn't even exist today as part of the North Carolina Health Realignment. And, probably, and I hate to say it, within 2 sessions of being in an outpatient therapy, I was like, this is not for me. Like, wow. I don't have the attention span for it. I don't think I had enough training to really do well by the people who really needed some really skilled care. Lucky enough to have a boss who said, well, you have to do some of that work because that's what we pay you for, but we're also interested in starting new programs and getting some grant money. Would you have any interest in that? I was like, sure. And so I started doing that, developing some programs, writing some grants, eventually left and started working for a private behavioral health company closer to this part of the state. And then began just program development work for about almost 8 years. So worked for behavioral health companies that primarily serve kids, would do a mix of looking at what would be some new programs we could develop and build, and then how could we spread to areas. There's a time when a lot of services were being privatized, not just in North Carolina, but other states. So going out and kind of responding to bids to take over running what were once kind of county or state-run services. So did a lot of that. I got a chance to be a little bit more creative and really thinking about, best practices. And did everything in those roles from going and finding the office in the new location to building the desk that the receptionist is going to sit in to ultimately getting these programs up and running, hiring a team. So did that for a while. And then just had the opportunity to transition to, at the time, it was a county entity. I was beginning to do some of the managed care work, doing just mostly utilization review and kind of member service functions. Did that, and just over time, that agency evolved from the course of 2010 into what it is today at Alliance. And played a role kind of in helping build the agency and overseeing clinical services, and then eventually more into the operational side.
Awesome.
So it's a long journey.
Great. I love it. And you've seen now so much of the transformation of the North Carolina care continuum, all the way from the actual community centers that you were working in early in the career and all the way up to where you are today. And I think there's been a lot of changes, right? If you listen to Kelly Crosby talk about it, she'll say that, 20, 30 years ago, the state of mental health continuum of care in North Carolina was not great. Like there were lots of problems with it. So can you maybe talk through like what have been some of the bigger arcs of problems that you've seen across your time, either at Alliance or prior,
Sure.
and how do you think maybe where we are today, how did we get here, and maybe how do we get here, I guess?
Sure. I think what's been a challenge, I think still a challenge, access has always, in my opinion, been a challenge. So I first came to work in this part of the state, was helping set up a program. And at the time, is before they really started privatizing most services, you might have to wait literally months to get appointments, get through the process. And, if you have any other illness in the world, you can't wait for months to get treatment. And behavioral health, I think, is also sometimes a condition of opportunity. People can sometimes, in a crisis point, when they reach out, can be really engaged. And that just wasn't happening. So I think, a lot of the work had been done to create better access, and I think that was happened through some of the privatization. And like anything, the first run at that probably was not super successful. So privatized, but some of the oversight and some of the historical skill and knowledge base that were in these community mental health centers didn't really expand out into the kind of the new, I guess, more private sector behavioral health companies. So I think that's been a challenge. I think over time, what's been the role of the LME MCOs is really looking, how do we, now that we have better access, and it's still not great, how do we now move from just access to something to access to better services? And I think a lot of us, I'll at least speak for Alliance, we spent a ton of time doing those kind of activities with the provider network. So we were never just saw ourselves as transactional, like here's a contract, here's our rate, sign it. It's like, here's a contract, we would like you to do services in this kind of way. Even if you can't do that today, we'll provide training. We run learning collaboratives. We've paid provider entities to go out and get trained in best practices with fidelity monitoring and make some serious capital investment. So I think the arc has been there wasn't great access. I think there was maybe some good quality, not great access, to a lot of access with a lot of problems that it was well documented in the state. There were lots of overspending, kind of fraud and abuse was rampant. Got those things under control. I think now it's still that balance of getting access for people with significant needs, but also evolving to current environment and current treatment needs. Again, I think how we came to work together, it's something for me that there's still this access issue, but even when there's access, the kind of current brick and mortar kind of way of accessing treatment isn't for everyone. It's not how people do most of their life nowadays. Like if you want something, you don't have to go to the grocery store to get it. You can get it online. If you want an answer to something, you can Google and get immediate response, but yet you're having some kind of challenge, anxiety, depression, things that would make it even harder for you to go travel someplace to get care. And there wasn't enough of this, I think, kind of enough technology-based supportive treatment available. And again, I don't think that's the answer to everything, but I like the idea that there's more options available. And I really see it as our job at Alliance to how do we make the most options available that work well for people, so people, so care can be better customized.
Yeah, which I think is great. I mean, I think every population has unique challenges. You've got tons of populations that you're trying to address, right? We're focused on youth. You've got adults. You've got the whole range. How do you, both you personally and then you internally as Alliance, how do you make decisions on what to tackle and when? Right? There's a limited set of internal resources that I'm sure you and every plan has. Like, how do you come to the prioritization of which problems are we going to tackle? There's infinite access problems.
Right.
How do you do it?
It's a mix. I think sometimes it's who screams the loudest, right? I mean, it's sometimes there are groups that are really good at drawing attention to issues where it may not be the biggest challenge, but it becomes a problem. And then I think there's also some things that are, you just see it clearly in your data. You start seeing things like emergency department numbers. You see certain age bands or certain individuals, certain kind of conditions are really showing up more where they are in places they don't need to be, where it's not going to help them. So you see a lot of people with more serious kind of mental health issues, particularly things like schizophrenia. spending way too much time trying to get care in emergency departments, spending way too much time getting locked up for, crimes of nuisance as opposed to getting the treatment needs. So I think you're looking at these factors. You're looking, we used to do these community needs assessments and get feedback directly. So you get all that stuff, and then you also then look what's out there. Do we have things available that we just haven't tapped? And are those the low-hanging fruits? There's this problem. There's kind of a solution. We're just not accessing it well. And then there's things where we have to go out and just be more creative and sometimes custom build a solution or look for a partner who could work with us to build a solution. So I think it's that mix of stakeholder feedback, it's advocacy, it's our data. And I think you can't help but have a little bit of personal experience as well. Like you have everyone who works there lives in the world, will experience some kind of mental health challenge, either personally or someone they love. And that perspective shaped things as well, too.
So having the perspective of the community and being so close to the community with Alliance, I think is clear why that would allow you to actually go and deploy more solutions that are more targeted and effective at the problems that you're seeing. But I think there's still something to the fact that, any health plan is a large organization. There's lots of stakeholders. There's lots of competing interests. There's lots of people screaming. And yet somehow, you all seem to be able to get things out into the world, to run tests. There seems like there is this, I don't want to say urgency, but I wonder if that is there a sense of urgency that you all feel to actually get these solutions both on access and quality out? And maybe can you talk to me about what's the internal feeling about the work that you're doing?
Yeah, I think that's a good way of putting it. I think we feel, I feel it, I know in talking with our executive team and actually all the people who work there, when we're aware of a problem, it's the worst feeling going home every night knowing that, there's people who have needs and we're just not getting it done. I think that the what's going on in the state with children in foster care is just such a prime example of that. The fact that there are children who are sleeping in DSS offices or are stuck in emergency room departments for days, weeks, sometimes months on end. It's hard to feel good, knowing that, I don't think that's our problem. We didn't cause that problem. It's not our problem to solve alone, but we certainly decided we have a piece in trying to solve some of those things. And then as we were building, working with the departments of social services, working with the counties, partnering to build some new things, every day these things weren't online. There was just this kind of pressure. And I know that's what I think drives a lot of people there, that here's just something that just feels so fundamentally wrong to you as a person. How do you not step in and do something? And I think that's the way our CEO leads. And I think that's really much the culture. And I think, again, so that's the way people look, but we're also small enough that we and can be nimble enough that we can test these ideas out. And if it doesn't work, we have a way of setting up that we're not going to be taking so much risk that we're going to bankrupt the company along the way. But I think we take these measured risks and take, reasonable amount of dollars to get things started, implemented, and supported. And we don't necessarily have to worry about making money off it. We just, at some point, it would be nice if we can break even, but also because of our partnerships, there are things where they may never be a break-even proposition, but we have partners who are willing to help out along that.
Yeah.
And I think the other thing is just the design. As these regional plans, we get, like every other health plan, we get a capitated rate that's actuarially sound, but if we do some things well, if we do some things efficiently, we actually get to keep that savings, and instead of it going into shareholders' pockets, it gets reinvested. And I think that's the smart design of the system. So you have this ability to, if you do the right thing, save some money, and then this pressure to address problems and then reinvest. I think it bodes well for this kind of publicly funded system.
Talk to me about the playbook. I think it's the people who I have found to be able to do things well in your world are the people who've got a playbook for testing new ideas in an environment where the downside is understood, so that way people aren't doing there's not a fear that, if we do something new and it doesn't work, it'll ruin everything. What is the playbook? Like in your head, what are the core pillars of running a test on a new thing? Like we've got this problem, we've got a solution, We've identified that we want to do it. We've decided that we're going to either build in-house or we're going to hire someone to do it, or we know someone in the community. What is the framework of like testing that you run?
I think the first thing is, it's always, is it safe? I think we always look at that as what we want. We're not going to implement something that's so far out in left field or so experimental. I mean, I think we have to at least know that this is, it's a safe, it's a well-vetted, it's an evidence-based practice. And even if it's an emerging model, it's based on really good principles. So again, I'll take something as an example. We did not work before with a digital health company that was providing virtual peer support to teens. We weren't even providing brick and mortar or in-person support to teens, but peer support's a well kind of borne out concept. The peers are supervised and trained. The company has top-notch medical oversight. So there's things in there that kind of, we look at that and say, okay, this is a safe. The company does a lot to mitigate the risk. It doesn't feel too super risky to go forward with it. So that's part of it. And then we're really clear on what we want to see. And not everything is about necessarily a return on savings. Some of it may be we have a problem around access. And, how do you solve for that problem with access? We have a problem around engagement and making sure we're clear what we want to get and understand you can't get everything from one thing. So I think that's part of the framework. Ideally, and this is where I think sometimes we get a little sloppy, then you have a framework for collecting data, doing this very detailed study and review and making sure it's bearing out and continuing. And I think there's probably been things we've run longer because people like them, that people are getting the service, and it was something new and novel that maybe it hasn't been tested out as well. And then there's some things we've looked at. It's very clear since we've done X, this many people have received access. Many people no longer go to an emergency room. These people now who used to only go for one primary care a year are going to 5 and getting conditions managed better. So I think whenever we do it, we look at is it going to really address a problem in a concrete way? And then is there some evidence that we'll have? And it doesn't always have to be financial.
Yeah. How often is it clear versus unclear?
The reality is it's probably never 100% clear, right? Because there's a million confounding variables. It's not a controlled environment. So, at the same time, someone uses, is going to therapy. If that also person, the family, in that home gets a job and, their transportation's better. Was it those things that really led to some better family function? Or was this new therapy? So it's never 100% clear. I think if it's clear enough, I think it's, for a non-scientific design of, I think that's enough for us to continue to go forward. But and I think there's, there's also an element of luck in all these things too, right? It's probably just like with any medicine you take. People don't exactly know, 40 years after Prozac was developed, people don't still exactly know how it works. Seems to work, and so people keep using it. And I think sometimes that's good enough.
Yeah. And you said you sometimes keep things along just because people like using them. It's like, well, if they like using them, there's some merit in that, even if it's not, like you said, not the financial ROI that you're looking for. There's some merit in that. I'm curious, as one of the tailored plans, and I think we could probably talk for a long time about the origin of the tailored plans and all the transition there, but your task is to support those with more complex behavioral health issues across the continuum. What does it mean to you that the state has, one, invested in the tailored plan as a model of care, but then on top of that has invested another almost $1 billion in their care continuum for mental health? Tell me how you think through that.
Yeah, for a start, I think it's really fortunate. I think that I would hope that part of that decision is that we've been in some form or other, the public behavioral health system in North Carolina has been around now for 50 years. It's gone through evolutions. But I think there is this understanding that the people who have been working in the system for a while really understand deeply the population. We've been covering as a managed care plan behavioral health services since 2013. So we've been operating that, and along the way, all of our attention goes to those people who really have the largest challenges and biggest needs. So I'm hoping part of the state's investments and acknowledgement, and we certainly feel fortunate to have that trust. I think the design, as we said earlier, just makes sense. I think, being kind of regional and not part of these big organizations allows us to not have to be so standardized that we can we can deliver care that's a little more flexible and a little bit more designed around specific needs, and not just say these are our processes as our service array and people have to fit into it. I think the investment in behavioral health services is significant for a couple reasons. I think around the nation, it's under-resourced almost everywhere. A lot of the things that have kind of helped the physical health world, the medicine progress, for a long time been left out of behavioral health. It's kind of newer that there's all this equity investment in behavioral health, even like healthcare technology, so behavioral health providers could track outcomes, track their sessions, kind of stay on track with providing more evidence-based care. They were left out of meaningful use. So there's just always been kind of left out of dollars. Even behavioral health services, the way they're billed, when you go, there's the one service you bill for. It's not like when you go to your primary care, they get to bill you for some vaccines, some blood draws, some, multiple tests. So you take one office visit and you have a way to make it a little bit more profitable and have cash in there. So you don't have that. So I think the acknowledgement from the state was this is an underfunded system, but also realize that the LME-MCOs alone could not solve behavioral health service issues for everyone. We cover a small portion of the population, and I think we do a lot and we contribute overall to what's going on in our communities, but we certainly couldn't do that for everyone. And I think the state's acknowledgement and investment was really important to say it's been an area that's been ignored for too long. There are things that just regional health plans couldn't solve, and I think they stepped in and did the right thing.
Yeah, there's almost this really interesting dynamic, which I've seen firsthand, given that Medicaid plans are the only health plans who are interested in like real new forms of behavioral health right now. Like it seems like the incentives across the commercial carriers are just to like not actually care that much about anything that is not pure standard. So you've got this weird split where like the Medicaid members have the access to some of the best behavioral health services out there because those plans are the only ones who are willing to invest in new things. And then you've got this long tail of folks on the commercial plan. And I would say specifically the folks who are on the lower side of the income spectrum for commercial, where they wouldn't qualify for Medicaid, but they're not making, maybe their annual household income is about $100,000 or less. That's not a household that's going to be able to easily afford niche behavioral health or outpatient services. So they're kind of getting left behind. So I think it is interesting to hear you say that.
I think it's weird. I get it. I don't necessarily think it's a fault of commercial insurance, but if you're an employer, right, and you have you probably as a general workforce, I mean, we know like people with serious mental illness, something like, I think it's still like people with schizophrenia, like 80% of those people are not in the workforce. So right away in the commercial world, they don't for adults, they don't have to offer some of the same range. And they do tend to offer more substance abuse services because that's more of a common experience. Where I think the suffering is for kids because, any child can have various issues. And then unfortunately parents don't have access to those plans, but the commercial insurance has this balance that they also have to be competitive and live within an employer's budget. So I think that's a bit of a challenge, but I think you're right. It creates a big challenge that you have. Unfortunately, you almost have to get really sick to drop out of the work world, become disabled before you can get services, where unfortunately some of the things we offer today, gosh, if you could have offered those to kids 5, 6, 7 years ago, think of the difference. And I think a lot about that when we were talking about before with foster care. Like a lot of times we get these kids where they're 16 and 17 years old, at the hardest to treat. And that's where you hear, and that's why these kids stay in the emergency departments for a long time. They've unfortunately, been through a lot of resources. They become really hardened because they've been bounced around, haven't got what they need. And I always think, gosh, I wish we could have had this 6, 7, 8, 10 years ago, what could have we done? And I think that's where we still have a lot of work to do. And that's the one thing I think I still worry about with our kind of tailored plan and standard plan dichotomy, that you're kind of in a standard plan for Medicaid or commercial when there's just less, where you have less service array. And as problems start bubbling up, do they have to really bubble and become really, really big before you get into a plan that's designed for you? And so that'll be interesting to see how that plays out over the next couple of years.
Yeah, and it almost continues to disincentivize preventative care because if the plan knows they're just going to get bounced off once they get to a certain level, it's like, why would we invest? So that's an interesting dynamic. Talk to me about youth mental health in the state. What I know we've obviously talked about this a lot, but like, what are you seeing are the problems that North Carolina has today with youth mental health, and what are the things that maybe you're most interested or excited about solving over the next 5-10 years?
I don't know if this is a North Carolina, I know it's not a North Carolina problem, but I think two of the things that I see, and I have a daughter I have two kids. I have a daughter who's 18, whose freshman year in high school was COVID. And the challenge of transitioning to high school in a virtual environment, and, it's a hard switch going from middle school to high school. You're already, in Raleigh at least, you might have all these kids going to one middle school and they go to 2 or 3 different high schools. So there's already this kind of split of friends, and all of a sudden to this major life transition, doing it virtually, and seeing the impact of almost a year of not socializing much outside the house other than a small little pod. Like, it took a while, and this was a really healthy and well-adjusted young woman, and luckily with a family with enough means that we could get her support. But it was a scary and challenging time. And I think about all the kids who maybe didn't have those kind of supports in place, or really the impact wasn't as obvious of that kind of social isolation and school kind of isolation. So I worry that we're going to continue to see this really generation of kids who really have a lot of anxiety, depression, and trauma from that time that just goes unrealized but continues to impact them. And so I worry about that a lot. I'm fortunate that things worked out really well for my daughter, but you could see how, if you weren't really attuned to the behavioral health field and behavioral health issue, you could have missed a lot of that kind of stuff. I worry about that. I worry about social media impact. And again, my daughter's home from college last night, 18-year-old, we're watching television, and as soon as a text comes in, the whole affect changes because something happened. It's this constant kind of bombardment of social media and almost nonstop communication. I think it really has, and I think we're starting to see it has a pretty dramatic effect on youth. And I worry about, there's all the typical problems that kids have had to deal with, and then the COVID, kind of all the social media pressures that it just, and I don't know if all the treatment we offer is really keeping up with all those things as well. From North Carolina, I think there's still probably not a greater issue for youth right now, in my mind, at least the kids we focus on these foster care kids who there's not enough foster care homes in the state, which means kids are staying probably in environments where maybe aren't optimal for longer amount of times, or they're getting stuck in multiple transition settings while they're waiting for a foster home, and then ultimately getting kind of kicked into the treatment kind of array. But even treatment residential services, those are short term. Yeah. And then where do kids go? So I think this kind of intersection of kids in DSS involvement, mental health challenges is in my mind kind of the biggest challenge facing the state right now.
Yeah. Take me like 10 years in the future, and take me to like the ideal world where everything that you do, that I do, that we all do actually makes the impact that we want. Like what does that look like in 10 years? And how is maybe specifically for these foster care youth, like what's different for them?
Even before going to the kids, I think I would hope that in 10 years from now, just the whole process of getting care, providing care is simpler. It's hard. It's still hard to find care. It's hard to get linked with care. It's hard for people to stay engaged in care.
Do you have any personal experiences or people that who've struggled with that?
Yeah, I mean, all the time. I shared with you earlier, I was up in New Jersey, and it wasn't, I was dealing with a family health issue with my father's getting older, who had kind of an unexpected health thing. This is a healthy, smart guy, has a PhD, navigating the care system to get him what seemed like simple care, simple tests, challenging hearing what it was not, I wasn't loving hearing this from an insurance side of things, but hearing all the doctors and social workers trying to figure out how are we going to get this through insurance because he really needs it. And to getting discharged home and having things in place, like all that was really difficult. It shouldn't be so difficult. So I'd like things to be easier. I think if things were easier, people would get things quicker. But how I'd like to see things, if things were better, I'd like to see that we're seeing less kids going into the DSS system. We're seeing kids not having to be waiting ever in an office for care. I think that you're seeing that you'd have kids who, if they do need care, it happens quickly, and then they're quickly reunified with their home, with their families, that they're not having to travel out of state to get care, why their family who is kind of needing things and needing help for everyone to reintegrate, get support. I just would like to see those things happen a little bit more seamlessly. And I'd like to see on the broader scale for mental health, I think it's a real shame for people with intellectual developmental disabilities, people with serious mental illness to still be so excluded from the workforce. So my ideal things would kids be living at home, going to school, and adults who are capable and able will have opportunities to work and real, because I think those other things are all healthy, and that's what makes us happy to have that other community. So that's my ideal state.
When you put it that way, kids at home, going to school, people at work, it's not rocket science. Mm-hmm. However, because it's people and because it's the 10 million people across state, it's complex to make happen. And it's no small feat. What do you feel like, what gets you most excited? Like what, I'm sure you mentioned earlier, there are lots of things that keep you up at night when a problem is presenting itself to you and the team, but like, what keeps you up with excitement about the future? Is there anything that you get really excited about?
Yeah, I am. I think I'm always excited to see like what new is going to be available to help. And I'm excited about the fact that I work for a place that's willing to invest in those kind of things. So if there's something came down the pipeline that seemed new and exciting, and I don't think I'm so creative that I'm ever going to go out and create one of these new exciting things, but I'm glad there are people like you who are.
Hey, don't count yourself out. You never know. You never know.
And could share these ideas. So for me, it's always exciting. What could be next? Like, what's the next opportunity? What's the next thing we could do? What's something we could do that we could show, even if it's not one thing, but how does this kind of, this crossroads of understanding the community, having a unique kind of delivery system, new technology, new money coming into the field, how could that lead to something new and exciting that we could tap into? And I'm still excited to learn. I don't think AI is going to cure all of our ills, but I am excited to see what we can learn and how we can understand more about who needs to be seen. Are we able to get ahead of things a little bit earlier? So that kind of excites me. How can we take kind of, apply kind of technology, good systems of care to these challenges and just get something better. And again, the idea that I work in a place that I'm really fortunate we get to test these things and implement.
So we talked a lot about this piece of Alliance is a place that both you feel empowered to try new ideas and test. The outside world also seems to think this is true as well. If I were a senior director of strategy or operations at a health plan in a different state, and I was looking to use Sean in this podcast for advice of, maybe I was frustrated by the fact that internally we all talked about wanting to do stuff, but just things never got done. Like, what advice would you have for me about how to actually get new things out into the world, how to actually try to improve patient outcomes, patient access?
I think kind of telling the right people the right story. Like, big complex organizations are hard to get things through. And also, I fall traps this all the time, but it's important to me, may not be important to anyone else, and really trying to understand like what is truly important. I think if you can show an entity, this is really important to the stakeholders, this is important, this is a real problem. We have data to support that this is a problem. We have stakeholders who are saying the same thing without the data right in front of them. And also, don't overpromise and start small. I mean, I think that's for me sometimes the idea we could start a small pilot, even if we know, hey, this first year, it may only touch 30 people, but that's, first of all, it's 30 people who weren't going to get something if we didn't try it. And if it works, then we have kind of more proof to move forward. So I think it's this find where kind of those things align, your data, your community outrage, and where you have a solution that seems a little novel that you can apply to it. I mean, and again, I have no idea in a big plan if that gets it done or not, but that's worked for us here.
Yeah. It's so interesting that you said the number 30, because I was talking to another person in a similar position at a plan we will not name here, who said specifically that was a number that was too small for them to care about, which I think highlights the absolute difference between the perspective that you get to bring to your community that they do and can, because for them it's too small. It's that it doesn't help enough people to warrant the internal investment that would be needed. And it sounds like your mindset is totally different. It's just like, we need to start small to prove that this works, and we can start small and be flexible and actually go and tackle this problem in a way that shows us if it's going to work before we take a big swing. We don't have to be confident about the big swing. Is that right?
It is true. And I think, it's like everything, rarely are humongous things built overnight, right? I mean, you kind of, even if, I think our difference is when we build something, we don't 100% know if it will scale up, but we think there's enough of an issue that we can make enough of an impact. And we have some programs that haven't grown, but they serve a small number of people and they serve them well. And that's okay too sometimes. I think we do that in housing. We offer bridge housing programs for people coming out of hospitals and people coming out of homelessness who really can't go right into supported, kind of community supported living. And, in some of our communities, we have 8 of these things. And so over the course of a year, it may serve 24 people. And I think we look at it, that's 24 people that without the service wouldn't have gotten the care they need.
Yeah.
And that's kind of enough for us.
If you had 24 people in a room and they all felt better because of something you did, you'd feel ecstatic.
That's right.
It'd be like amazing. But there's this unfortunate reality of when the numbers in healthcare get big, you forget that these are actual people.
Sure.
I think that's not a unique problem to you or I or anyone, but it is helpful to be reminded. And I do think, again, like there is something to be said about the work that you do is in the community, and you are emergent from the community. It is not as if this is just a line of business for you. Right. This is the business. It is to be here. Do you have a sense of like what you want your legacy to be, or what you want you to leave behind in your years at Alliance and in the community that you serve?
It's funny because probably in a typical chief operating officer role, it would be like that role would be all the internal systems and process. So first I have to say I'm very fortunate because I really get to do a little bit of both. I get to look at the kind of the boring, mundane stuff. How does something travel through our system? How do we make our contracts better? But the part obviously you can tell I think I'm more excited about is like bringing new services. And I think hopefully for me in Alliance, I think it will be the number of new things we brought to help people. And just a dumb story of this. I never thought much about it. I was my daughter was getting her haircut once at her stylist, and her stylist was telling my daughter, because she has a daughter her age, unfortunately my daughter had to go to this hospital. There was this new program that was open. It really seems to it helped. I didn't have to take her really far away. My daughter was telling me about that. I was like, I remember like 7 years ago sitting down with a provider who had this cool idea, and we brought this program to life. And so for me, I love that, the legacy that there's actually concrete things that, again, it wasn't me alone, but I was able to do my role to help bring to the community and to bring to people. And, whether it's one or maybe thousands of people over the years go through it, I'll feel good about that.
Love that. All right, my last question. If you could snap your fingers and you could change anything about the world as related to improving youth mental health, we'll say nationwide, not just in North Carolina. If you could snap your fingers and change one thing immediately, what would you do?
It's a great question. I would want it to be as easy to get care as it is for kids to do anything else these days. Again, whether it's be able to pick up their phone, do something, and get either information, immediate support, a referral to treatment over their phone if they need be. I would just like it to be easier. And I think it's getting better. I would like there to feel like there's no stigma or shame. I mentioned, again, I just don't want to keep harping on my daughter, but I mentioned I was doing this to her today. I said, hey, I might want to talk a little bit about, how COVID was. I don't know if it'll come up for us. And she's like, yeah, you can talk about that. It's fine. People have these kind of struggles. And I hope that people feel like empowered to get help and not feel any shame about it. And then I hope it's just easier for them to get.
Love it. Thank you for the work you do. Thank you for leading the charge here. I say this to everyone, but North Carolina as a state system is looked upon as like the true leaders in mental health right now. So kudos for all the work you're doing. And yeah, thank you for the time today.
Thank you. Thank you for having me. And thank you for supporting our members as well.
Cool. Awesome.